Hello, everybody. So my name's Sprouse Blum, and I'm a family medicine doctor. I did a fellowship in headache medicine. I work at the University of Vermont Headache Clinic, and happy to be talking to you today about 20 common migraine myths. So let's get into it. All right, myth number one. So myth number one, the other thing I should mention is feel free to, in either the chat or the Q&A section, put your questions, and the talk will be about 30-ish minutes, and then the second half we'll go through all your questions. All right, so myth number one, kids don't get migraine. So it turns out kids do get migraine. About 1 in 10 kids get migraine, but actually as early as infancy, you can see predictors of later development of migraine the way that we think about it. So for example, kids with migraine are more than 6 times more likely to have experienced colic as an infant. Some of you might be familiar too with these episodic syndromes, which tend to be in kids, and they predict later development of migraine. So there's 4 of them: abdominal migraine, cyclical vomiting syndrome, benign paroxysmal vertigo, and benign paroxysmal torticollis. So these tend to occur in kids. As you know, they can occur later in life as well. And kids that have one of these syndromes tend to go on to develop migraine the way that we think about it later in life. Some interesting facts about migraine in kids. So we usually think about migraine disproportionately affecting women, but in kids, migraine actually affects boys and girls equally, until women hit menarche, onset of periods, at which time they kind of separate out. Also, in kids, migraine tends to be a little shorter in duration and tends to be more bilateral. So kids get migraine. Myth number 2, men don't get migraine. Turns out that while women are affected by migraine 3 times more commonly than men, that means that there's 1 man for every 3 women with migraine. And there's some slight clinical differences between men and women with migraine when studied. For example, men with migraine tend to have onset a bit later in life. They tend to have fewer headache days per month that are slightly less severe and have a little less disability associated with them. It's also worth noting that men are less likely to consult a doctor for their headaches, and that when they do, they're less likely to receive a migraine diagnosis. So men get migraine, and it's important to bring it up when it's suspected. Myth number 3, migraine equals severe headache. So this one is one of my favorites to dispel. Most people think, I think I'm going the right way for y'all, migraine equals bad headache. But it turns out that all of the symptoms of migraine are just as much migraine. So for example, sensitivities to light, to noise, to smell, nausea, sense of disequilibrium, pain in the mid-face. People are thinking they're having sinus problems, pain at the base of their skull. They think they're having neck problems. It's just that for many people, the headache is the most bothersome symptom. And that's why most people equate migraine to severe headache. But all of the symptoms are just as much migraine. Myth number 4, migraine pain is due to vasodilation. So I think this is what many of us were taught in medical school, and that was called the vascular theory of migraine. And that's largely fallen out of favor. The pendulum swung, like it can, from a vascular theory to, migraine's a purely neurologic disorder. And then, over time, I think now we're somewhere in the middle where we recognize that the pathophysiology of migraine is complex. It involves multiple systems, of which the vascular and neurologic systems are both involved, but others are too, for example, the gastrointestinal. So I actually have a bonus myth. Tension type headache turns out is not due to tight scalp muscles. So basically everything we were taught in med school is wrong as it relates to headache. Okay, myth number 5. Migraine pain must be throbbing. So this one is easy to dispel, or short at least. About half of patients with migraine experience attacks that are throbbing. So that means that the other half It's a non-throbbing type of pain. Myth number 6, you can't diagnose migraine without aura. So only about a third of people with migraine experienced aura in one form or another. And whereas most people are familiar with the visual type of aura that happens, there are other common aura types that are important to keep in mind. For example, sensory auras, classically a numbness, classically affecting one extremity, maybe moving up the extremity, possibly affecting the face, sometimes the tongue. There's also speech language auras where people might have garbled speech, or they know what they want to say, but they can't say it, or they switch words. So there's more than one type of aura. Those are the more common ones: visual, sensory, and speech language. So you don't have to have aura to have migraine, though. Only about a third of people do. Myth number 7, aura occurs prior to headache. So that's, again, the classic teaching that aura precedes the headache phase of migraine. But it turns out you can have aura at the same time of headache, and you can also have aura in isolation without headache. Many patients that have migraine with aura also have aura without headache. Myth number 8, blurriness equals aura. So it turns out about greater than 40% of people with migraine report blurred vision with attacks. But general blurry vision affecting like the entire visual field is not generally thought to represent migraine aura. However, patches of blurry sometimes do meet criteria for migraine aura. Something that I have to do is I'll pull up the International Classification of Headache Disorders, which you can easily Google. It's free, it's easily accessible. And I'll pull up the migraine aura bit because the aura criteria have actually changed fairly recently. And I'll have to go through them to see if the patient actually meets criteria for aura. I have a couple of tips related to this. So tip number 1, migraine auras tend to spread. So the visual disturbance might start in one place and kind of spread, or the numbness, it might start in the fingertips and move up the hand, that kind of a thing. That's a bit different than TI, transient ischemic attacks, which tend to be sudden. So that can be a helpful feature to distinguish TIA versus aura. Which relates to my second tip, is to diagnose migraine aura, it has to have happened 2 times. So the first time that someone has a migraine aura, you don't always know. And so that can be a challenge the first time someone has a migraine aura. Myth number 9, sinusitis is a common cause of headache. So this is an important myth to dispel. And the reason I say this is because I work at in a headache clinic where headache disorders and migraine are all that I see. And it's quite common that I'll have a patient who has mid-face pain, and they've undergone multiple courses of antibiotics with temporary relief, but the problem keeps coming back. And some of them have seen ENT, and some have undergone ENT surgery. But migraine often presents mid-face. So let me read you a couple research stats. So in a study involving greater than 400 primary care study sites, including about 3,000 patients with self-described or physician-diagnosed sinus headache, 80% met criteria for migraine and 8% met criteria for what's called probable migraine. Probable migraine is you meet all of the criteria for migraine -1, and we treat it the same. So 88% of those patients met criteria for migraine. Here's another study. Among patients with refractory rhinosinusitis, CAT scans were done of their sinuses, and the severity of sinus disease was graded using 3 different systems. And what they found was that there was no correlation between mid-face pain severity and the disease severity on CAT scan. A third brief one is among patients with sinus headache, the severity of sinus disease on CAT scan did not differ in those who met versus did not meet criteria for migraine. So migraine often presents mid-face, when it does, it often gets misdiagnosed as sinus headache. And that's not to say that an acute infection with, increased white count, fever, and et cetera, viral illnesses in particular, infections can cause headache. So it's not to say you can't have headache from a sinus infection. It's just that when you see this picture of someone that has recurrence of this problem, it's really clear when they have imaging and they have clear sinuses and they go, okay, so look for other migraine symptoms when they have their mid-face pain. This is another one which is kind of in the same vein as the sinusitis. So myth number 10 is that neck pain is rarely a symptom of migraine. So in a systematic review, 77% of people with migraine reported neck pain versus 23% in a non-headache control group. The neck pain of migraine is thought to be due to a connection between the upper two cervical nerves and the trigeminal nerve converging, which they do. They converge in the brainstem, and that area in migraine can be hyperactive. And then the brain can't tell, am I getting symptoms from head or upper neck? So many patients with migraine have neck pain, and in my experience, it's typically base of skull, upper neck. Halfway done. How are we doing on time? Good. Myth number 11, pain at the back of the head equals occipital neuralgia. So this kind of ties into the last one. So it's another not uncommon situation where a patient will come to me with a diagnosis of occipital neuralgia. And so, as mentioned, patients with migraine often have pain at their base of skull, upper neck. And so when they have that, they're sometimes misdiagnosed as having occipital neuralgia. But keep in mind what neuralgias are: pains of nerves, right? So for example, the occipital nerves, you can't really see it, but there's actually 3 on each side. There's a greater, a lesser, and a third. The occipital nerves they come under the skull, and they end at the top of the head. So occipital neuralgia should not extend beyond the top of the head, beyond the end of the nerve. And when you ask these patients, where does their pain go? They'll say, oh, it's at the back. And then I go, oh, well, where does it go? Well, sometimes when it's bad, it'll go to my temple or it'll go to my forehead. So that's not what you would expect in occipital neuralgia. There's obviously exceptions to rules, but in general, that's what you want to look for. Same with trigeminal neuralgia. So some truisms with neuralgias is that they follow the distribution of a nerve without extending beyond it. And they tend to have paroxysms of pain, and they tend to be unilateral. It's often a compressive etiology. So it would be, as you can imagine, it would be kind of hard to have compression of both nerves at the same spot on both sides. I mean, it's possible, but it's just not common. So neuralgias are typically one-sided. Paroxysmal pains follow the distribution of the pain. Myth number 12, all severe headaches require imaging. So let me read to you what 2 societies say related to this. So myth number 12, the American Headache Society says there's no necessity to do neuroimaging in patients with headaches consistent with migraine with a normal neurologic examination and no atypical features or red flags. Like other conditions, red flags exist. There's a mnemonic called SNOOP. It's gotten really long over time, but it has a list of red flags. Here's what the Choosing Wisely campaign says. Don't perform neuroimaging studies in patients with stable headaches that meet criteria for migraine. They also say, don't perform CT imaging for headache when MRI is available, except in an emergency setting, like looking for a bleed. So in an outpatient setting, patient has headache, you're concerned for secondary headache disorder, get an MRI. Myth number 13, patients need to figure out their food triggers. So it turns out there's only a few foods that are consistent food triggers across patients. So the most classic one, I think, would be alcohol. So red wine is a classic one, but there's others that are less consistent. Things like monosodium glutamate, MSG, nitrates and nitrites, which are often in processed meats, chocolate, which contains a caffeine-like substance called theobromine, and dairy products. As it relates to caffeine, caffeine's an interesting one, right? Because it's in some over-the-counter combination medications, but also people say, oh, when I drink a cup of coffee, it helps my headaches. So caffeine works like other pain relievers. Taken occasionally, it can work for pain relief. Taken frequently, when you don't get it, you can get rebound headache. Another point about food triggers for patients with migraine is that I think people tend to figure out for themselves what their food triggers are. If there's something that's consistent, they tend to figure it out. But people sometimes go on sort of this mission to figure out what their food triggers are. And what I've seen happen is it's almonds. I'll get rid of the almonds. Oh, but I got a migraine again. Maybe it's avocados. Avocados is what it was. Get rid of the avocados. No, bananas. And over time, they end up with this restrictive diet and they end up feeling defeated, and it can be just not productive. Myth 14. And I don't want to say that if they do have a migraine trigger, not to avoid it. If they figure out they have a migraine trigger, then you should avoid it. Myth 14, migraine can pop up at any time. So when I take a headache history, basically all the new patients that I see, I take the same history. I say, when you're a kid, did you have headaches? And for women, of which most of my patient population is, since migraine disproportionately affects, I say, at what age did you start having periods? So age of menarche. And I say, through your teenage years, did you have headaches? Do you have any kids? When you had if they had kids, when you had your kid or children, did your headaches change around the births of any of your children? How about in your 40s? At what age did you have menopause? And so I hit up these hormonal milestones because migraine tends to pop up or shift around one of the hormonal milestones. So in the headache history, it's important to ask about menarche, birth of kids, and menopause. And when you do, you often can get a reassuring story that, oh yeah, I had onset of migraine a couple of years after menarche, for example, where they changed after the birth of my second child. That kind of a thing. Myth number 15, avoid triptans in patients with aura. So, presumably people would worry something about, stroke and triptans and something related to this. But in reality, in the headache field, we don't restrict triptans for patients who have migraine aura. There's 5 more left. Okay, myth number 16. Triptans should only be used 2 days per week. I did a little digging and I can't quite figure out where this myth came from, but I see it frequently on prescriptions. I also see don't take more than 8 tablets of a triptan in a month. So a little information on this. I looked in the prescribing information, the little thin paper that comes with the medications. And for each of the triptans, they say the safety of treating on average more than 3 or 4 headaches in a 30-day period has not been established. But then you go down to the dosing instructions and none of them have any comments about limiting use to 2 days per week or anything of that nature. So then you get to thinking, well, what about, cardiovascular risk? So the American Headache Society previously put together a triptan cardiovascular safety panel, and they put out a consensus statement with 4 pieces to it. Number 1, most of the data on triptans are derived from patients without known coronary artery disease. Remember, migraine used to be thought of as a vascular disease. So when triptans were studied, in the 90s, they didn't enroll patients that had, heart attacks or stroke because they were worried that vasoconstriction would cause one of these bad outcomes. So most of our data is from patients without known coronary artery disease. Number 2, the chest symptoms occurring during use of triptans are generally non-serious and not explained by ischemia. So common side effects of triptans include tightness of the, face, neck, or chest. And this is not thought to be cardiac related. Number 3, the incidence of serious cardiovascular events with triptans in both clinical trials and clinical practice appears to be extremely low. So I can't say nobody's had a heart attack or a stroke after taking a triptan, because rarely it has happened. But it's much But when you look at sort of people's concern versus the reality of how often that may happen, there's a bit of a mismatch still. Number 4, the cardiovascular risk-benefit profile of triptans favors their use in the absence of contraindication. So that being said, I don't prescribe triptans. If someone has a contraindication, I would have no grounds to stand on. So common contraindications include coronary artery disease, history of stroke, peripheral vascular disease, uncontrolled hypertension. I think one thing that we do as it relates to that 2 days per week of use of triptans is we try and avoid medication overuse headache. So the definition of medication overuse headache is prescription pain relievers and those that have multiple in one combination analgesics is 10 days a month or more use, then you're at risk for an overlay of medication overuse headache, greater than or equal to 15 days per month of other over-the-counter analgesics. So we try and limit triptans to less than 10 days per month. It doesn't mean you can't take, a triptan say 2 times a day for multiple days, but you still want to keep it less than 10 days per month to avoid risk of overuse headache. Myth number 17, never prescribe triptans with SSRIs or SNRIs. So the American Headache Society put out a position paper a while back that said the currently available evidence does not support limiting the use of triptans with SSRIs or SNRIs due to concerns for serotonin syndrome. So I have many patients on more than one either SSRI or SNRI, and I don't hesitate from prescribing triptans. These as-needed medications very rarely are an issue as it relates to serotonin toxicity. A few more left. Myth number 18, newer agents require training to prescribe. So until not that long ago, there was really nothing on the market for migraine prevention. And there was only one class of medication, the triptans, made for acute treatment. We now have several more options, as we know, because we're often getting advertisements and patients are getting, and we're getting asked about these types of new medications. So there's, I'll give you a brief rundown without giving you any names. So there's 3 self-injection monoclonal antibody drugs that are addressing this protein implicated in migraine called calcitonin gene-related peptide CGRP. And these self-injections are some of the easiest medications I prescribed. They're well tolerated with only a couple of caveats. So I do avoid one of the 3, iranumab, in patients with a history of constipation. Of the 3, this one seems to be more associated with constipation than the other 2. Also, with these self-injections, skin reactions are common. So people, I often give patients a heads up that, the place where you inject it is probably going to get raised and red. And so, you can pre-treat with diphenhydramine. You can let the injection warm up to room temperature and things like that, but try and help minimize it, but it can be a problem. There's also 3 GPANT drugs. So these are oral drugs, and they also work on the CGRP system. And there's 3 of them, but it turns out one of them is FDA approved for acute treatment. One of them is FDA approved for both acute and prevention. And the third is approved just for prevention. So over time, we might find that, these drugs end up more get approved for both, but currently that is the situation that they're in. And the GPANTs can be a good option for patients that have contraindications for triptan medications. So those 2 that are FDA approved for acute treatment, in a patient with a triptan contraindication, that can be a good option. There's also one ditan medication, which happens to also be a serotonin receptor medication like the triptans, but instead of 5-HT1B serotonin receptors, it's 5-HT1F. So that's also okay to take in patients that have contraindications to triptans. There's one caveat with that drug. It's the prescribing information says not to drive or operate big machinery for 8 hours after taking. So that can be a limitation, but it works pretty good for the patients that I've had taking it. Okay, 2 more. Myth number 19, migraine prevention is for life. So, it's important not just to go forward, but like other medical conditions, when someone's doing well and there's a possibility of removing a medication, we should always consider that. So there's no real great rules of thumb for this, but 3 to 6 months of good control, whatever that is for the patient, is a reasonable way to go about it. Sometimes patients find that headaches start creeping back in, and then they'll have to decide whether to restart the medication or not. But I always tell patients the lowest of medication that controls your symptoms is what we're after. So think about removing layers of migraine prevention when possible. And some patients require more than one. Some require 2 and sometimes 3 layers of migraine prevention to get their migraine under control. Myth number 20, there's nothing to offer for migraine in pregnancy and lactation. So rather than give you specific agents, I would recommend doing what I do. So go on Google Scholar, for example. If you look for migraine management in pregnancy and lactation, you'll find some good articles. I like the ones that have tables, and it breaks it down by pregnancy and lactation, and it gives you sort of first, second line and what to avoid, things like that. And so evidence is changing over time. Every time I have a patient who's pregnant that I'm treating for migraine, I will pull up that article. I will often, now that a lot of things are on video, I will share my screen with them and I'll look through the evidence with them. And so that's how I go about it. So that is all 20 myths. Oh, I will say that there's a lot more resources on our website. It's called American Headache Society First Contact Headache in Primary Care. So for example, we do have a couple of presentations you can sign up to have presented by one of the headache experts. It's free. They come to you, all expenses, are taken care of. It's CME based. You get CME for it. And there's one on family and internal medicine. There's one on women's issues specifically, and we're developing one on pediatrics. There's other things like patient guides. You can go in and you can have a PDF emailed directly to the patient about some sort of common questions that come up from patients. There's a flow chart, etc. So I should stop sharing my screen and do questions. Okay, let's see here. So feel free to put questions in the chat or the Q&A, and let me take a look. Okay. So in the Q&A section, let's see what we got. So is there a common, I'm just going to go top to bottom here. So is there a common age group range for men who experience migraine? I don't know. I mean, I know that in women, it tends to peak, I think, between 20 and 45. And I can see a picture in my mind of the prevalence of migraine in men and women. And if I remember correctly, it's similar in men. It's just that the curve is shifted down, threefold. I think that's the right answer. Do you have tips on how clinicians can differentiate if the pain is from the migraine or neck? They're kind of moving. Let me see here. From the migraine or neck? Yes. So here's a situation that I'm in. So I'll have a patient who's, when's the last time you saw a 65-year-old with a perfect neck? It can happen, but it's often not the case. So say you have a 65-year-old person, they have arthritis in their neck. Say it's moderate arthritis. One tip that I use is I'll say, is your neck pain at the top or the bottom of your neck? Because often arthritis is at the lower, more so at the lower portion of the neck. And I don't give the middle of the neck as an option. Is it top of your neck or the bottom of your neck? And if they say top of their neck, that's one thing. And then the other thing is, when they get the neck pain, do they have any other symptoms attributable to migraine? So do you have nausea with it or sensitivities to light, noise, or sound? And so these are the kind of features that can be helpful in distinguishing the two. Are any of the GPANs approved for children? I'm almost certain that I am answering this correctly, but no, I believe there are no GPANs currently approved for children, but there is a need for them, and I believe that there's multiple clinical trials going on currently related to that. What ICD code do you use for probable? Oh, okay, ICD-10 code, right. So it's easy to get mixed up between International Classification of Headache Disorders, which is ICHD, and the ICD. So what ICD-10 code do you use for my probable migraine? I put in migraine with or without aura, and then in the comment section, I put probable migraine. That's the best way that I've currently come up to deal with the probable migraine diagnosis. Sorry, I missed what you said. Which CGRP blocker causes constipation? So in my experience, I avoid Erenumab, which is one of the injectables, in patients that have a history of constipation. Here's another one. Does the absence of neck pain between migraine attacks make you more likely to think the neck pain is migraine related? Let me say that again to myself. Does the absence of neck pain between migraine attacks make you more likely to think that the neck pain is migraine? I think I see what you're saying. So I think that would be the thing that I was saying about like look for other symptoms that would be attributable to migraine. So see if the neck pain occurs with those other symptoms. But yeah, I totally agree. If the neck pain occurs with those other symptoms and it's exclusively it comes as a package, then that's another support feature that the neck pain is migraine related. That is all the questions. If anybody has a last question, I'm happy to answer it. And if not, I'd like to thank everybody for joining today. And feel free to go to our First Contact website where you might find some helpful resources. See y'all later.